one of the best lines I've ever heard in a talk was, "Cancer is very, very, very smart." And so if we want to defeat it, we need to be smarter.
It's really about teaming with people. It's really about making care better. And there should be no walls between physicians or even physicians and patients.
So we have a group called MTOP that gets together on Tuesday mornings at a tumor board. And all of us discuss the most complicated patients. And by the end of the conference, we always have what we think is the best conclusion on how to care for each patient.
Particularly for complex cases, having everyone in the same room looking at the same data together is very, very powerful. While all of us work hard and we like to think that we're smart, we're much smarter and much more effective when we're all in one place talking about the same data together.
After that, we then break and then go to our clinic, where the thoracic surgeons, the interventional pulmonologists and pulmonologists, medical oncologists and radiation oncologists all hold clinic physically within the same clinic space, so we can easily bounce cases and ideas off one another and best manage patients.
We're actually contacted quite a bit by folks around the state as well as the country, and that's actually something I think we enjoy the most about our job, is not only are we taking care of patients directly, but we're also able to help in the care of patients we may never even meet.
I think physicians would gain a lot from referring patients to UNC when they either need help or would like to team with a treatment team that has a true multidisciplinary approach to lung cancer treatment.
Patients are referred in for things that we can uniquely offer at UNC. No patient should ever drive 4 hours to UNC to get standard chemotherapy. And so for that patient who is better served by a good community doctor who knows them, who knows their community, and who's 10 minutes away instead of 4 hours away, quality of life is better with local treatment.
So that's something that we really do try and strive for, is we not only keep the outpatient oncologists in the loop, but also try and find ways in which maybe they can continue some of the treatment closer to home.
Right now it's the wild west of thoracic oncology. You could get a brawl going at a national conference by presenting a 3A patient and asking what to do. The hopeful piece of this is that we've never had such an explosion in science. We've never had such an explosion of understanding how lung cancer works, and we've never had such an explosion of new therapeutics that exploit that understanding to deliver better care to the patient.
Clinical trials currently, in my opinion, are everything in caring for lung cancer patients. I think one of the things I like most about our portfolio of clinical trials is it really helps meet the needs of almost any kind of patient with lung cancer.
We're on the cutting edge of cancer care. So oftentimes patients are on their second, third, sometimes fourth line therapies, and they've run out of options. And so in being able to give patients further options is quite important. I'm very, very excited about where cancer research and treatment is going. I think that technology is advancing by leaps and bounds. Molecular genetics and the treatment of cancer is also jumping forward by leaps and bounds.
What's exciting is that we have all this promising targeted therapy and immunotherapy that actually works.
So while we're learning so much about it and really starting to see some success in treating it, there's still so much further to go. And so I think what excites me is that great challenge.
At the end of the day, we have two goals and two goals only. We want our patients to live longer, and we want that time to be with a high quality of life.